leading corporate leaders and social sector leaders, we bring to you yet another conversation to explore how strengthening of our public health system is in our enlightened self-interest. This second session of our Leaders with Purpose series will discuss the gaps in India's public health system and healthcare sector, highlighted and exacerbated by the COVID-19 pandemic and the role that private sector can play. I just wanted to spend a minute talking about the work that Samhita is doing to support our migrants and our workers. We have two alliances, the India Workers Alliance to provide immediate relief to our workers and help them get back on their feet. Our India Protectors Alliance protects our protectors, our frontline healthcare and sanitation workers. And today's conversation is a little bit about how do you really strengthen our response to our frontline healthcare workers. A few housekeeping rules. We request you to post your question in the Q&A section only. All questions will be answered at the end of the session. Please join me in welcoming Professor Manoj Mohan. Over to you, Manoj.
Thanks so much, Priya. It's wonderful to be here. Hello, everybody who is joining us on YouTube and on the Zoom webinar. And I'm a professor at the School of Public Policy at Duke, and it's wonderful to welcome our guests. We have 5 incredible members on our panel today. What I'll do is I'll briefly introduce our 4 or 5 panel members, and then when we pose questions, hopefully we can try and follow in the same order, just to keep things transparent and easy on the webinar. So first we have Dr. Shamika Ravi. Many of you followed Shamika's work. She's a senior fellow at Brookings Institute, and she's also a member of the PM's Economic Council in India, and is also a visiting faculty member at ISB Hyderabad. We then have Dr. Siddharth Shah, co-founder and CEO of Ascent Health and PharmEasy. And together, Ascent and PharmEasy now, which is known as API Holdings, form the largest digital healthcare platform in India. They connect over 50,000 pharmacies and 1,500 pharma companies with a ton of doctors and millions of patients every month. We have Dr. Dilip Jose. Hold on for a second, my comments just went. Dr. Dilip Jose has got 32 years of professional experience. He's a leader in the healthcare delivery industry now, and before that, he's had a lot of experience in finance and corporate planning. We also have Dr. Krishna Reddy. He's a cardiologist, co-founder of Care Group of Hospitals, and presently the country director of Access Health International. Access Health is a think tank that works in health systems with presence in China, ASEAN countries, including India as well, and also in the US. And we also have Dr. Nachiket Mor. Dr. Nachiket Mor has been, for the last decade or so, pursuing his interests in health systems design in a variety of roles. He's currently a visiting scientist at the Banyan Academy of Leadership in Mental Health. And among other things, he teaches also a week-long seminar on health systems design there. So without taking away much more time, let me start with an overall question. What we'd like to hear from all of our participants, and we could go in roughly the same order, starting with Dr. Shamika Ravi. If you could tell us a little bit about the work that you've been doing, and specifically how your institution has been contributing to the COVID crisis, response to COVID crisis, and what we can learn from your efforts in there. So over to you, Shamika.
Thank you, Manoj. Very happy to be here with everyone, virtually connected to many of you. Well, so Manoj, first of all, I'm no longer with Brookings Institution in India, which is wrapping up soon. As an independent researcher, as an economist, I think these are difficult times for the society, but these are also times when we have to rise to certain professional duties that are expected of trained economists, trained empiricists globally. And you can see that it is happening in almost all countries that are well connected on social media on a day-to-day basis. And also, frankly, in the medical journal part of academia, there is a lot of real-time research coming out. And that, frankly, is our job, to read the amount of data available. No country is putting out perfect data, perfect, let's say, individual level, patient level data. So there are many maybe part from Germany a little bit. So we have to do a lot of analysis to really make sense of where this crisis is in different countries. And being an Indian in India, for me, it is of great concern and professional service to really muster all my empirical knowledge to really make sense of the Indian data. Well, what I have been doing over the last 6 weeks now is looking at the Johns Hopkins data, and also, frankly, looking across data sets because there are certain discrepancies. You also have sort of independent, separate data sets that are being put together. So the WHO and the Ministry of Health and the government data is of one form. Johns Hopkins and the ECDC outbreaks is of another. And so we are analyzing all this data. And very early on, it became clear that we were seeing discrete changes in the nature of the outbreak if you begin to see the growth part of it. But broadly, just making sense of what is happening to active cases, let's say, much against a lot of the epi models, which were quite frightening in the beginning. And frankly, also the motivation for a lot of us to really, enter, sort of dig deep into the data and provide a statistical analysis of the existing evidence. So unlike the epi models, which basically rest on many parameters, which have not been estimated for the Indian population. And that is one of the reasons why we did have very alarming predictions and projections for the future, amounting to almost 400 million, sometimes 600 million, some projections said. Very alarming indeed. But when you begin to look at those early epi models, we realize that the parameters were all really lifted from the OECD countries. So it's very important to contextualize and put it in an Indian context. And of course, India is 1.38 billion. It's a very large country. It's almost like speaking for the entire European Union instead of individual countries within Europe. So we also started to then look at the crowdsourced data put together by COVID-19india.org, which is a very commendable exercise put together by a bunch of youngsters. Occasionally, they go back and forth, as is expected in a crowdsourced data, but very good data. So at the state level, it is useful to put out information on what is happening to the outbreak. In particular, looking at not just overall confirmed cases, but also looking at what is happening to testing, what is happening to recovery rate, looking at basically what is, the number of, so what is the mortality, the COVID mortality per million. We knew very early on that looking at case fatality could be very flawed simply because different countries are looking at, are doing very different kinds of contact tracing and really struggling to stay ahead of the infection. So we started calculating the COVID death rates per million very early on. And then, of course, a lot of these methodologies were subsequently also adopted by Johns Hopkins and now, by a lot of the public health sort of institutions. A lot of them are co-authors. We have just published a series of papers on German data because they do put out individual level data, and some intriguing findings are coming out. For instance, that the morbidity difference across the genders is actually, it is growing over time. So as the pandemic has expanded and increased, as the infection has increased in Germany, the gap between male and female mortality has only widened. So that was one quite a fascinating finding, and we're trying to dig deeper into why that might be the case. It's clearly not driven by smoking habits, which was the case in China, etc. Then another finding is that the mortality numbers are highest, of course, for very elderly people, so 80 plus, but the second highest mortality numbers are registered for the working age population. Meaning relatively the 60 to 80-year-olds are quite safe if you look at the mortality numbers, which seems to suggest different policy interventions that were taken in and the susceptibility of the working age population. So we are trying to bring in a lot of those findings into the Indian setting. We have been also analyzing some hospital level data. So for instance, when we find that not only has the infection rate being fairly linear if you compare with other countries. In the Indian case, it is exponential, but seemingly linear because it's really happening at very low growth rate. But what is striking is the mortality numbers in India are quite muted. And this is also borne out if you look at hospital level data. And we have analyzed more than 100 hospitals across the country. And we are seeing that, the incidence of respiratory ailments, people coming with these respiratory ailments because the symptoms are very similar to COVID symptoms, are actually looking very similar this year to the last 2 years. So, you really have to read multiple different types of data that are becoming, public. And researchers like us really put it to certain models, put it to certain theories, try to make sense of it. But very importantly, also, once we know what we have in terms of empirical evidence, communicating it to people. And I think because these are times when people are very scared. And very importantly, we do know that in India, given the research capabilities across not just public institutions, but also across a lot of our private institutions, there is very little real-time knowledge coming out. And I think at that level, a lot of the response teams that have come together, which are really like track 2 teams to support state governments and central governments, which comprises of scholars across the globe who are all very concerned about the Indian situation. And we all want to contribute in our own ways. It's a large team that I'm a part of. It is not just limited to Brookings. It pans across multiple different institutions, but almost all of us are economists with training in applied and health economics. So that's the background, Manoj, of what is the contribution that we're trying to make into the current situation.
Thank you so much, Shamika. We will definitely want to come back to you with more questions on that. So right now, let's switch gears and hear from Siddharth Shah about what they've been working on. Siddharth, over to you.
So thanks, Manoj, and thanks to the entire team at Samhita and Priya for having us on this. So I think there are a couple of things that at least we're working on, right? So I'm going to take about 30 seconds to tell you what we do. We run a couple of digital platforms in the country. So one of our first platforms connects about 1,500 plus pharma companies with 50,000 retailers, right? So we're the largest marketplace for these pharma companies to provide medicines to these 50,000 retailers. The second platform that we own, which is Pharmeasy, is an online pharmacy, which is a marketplace which connects these retailers in turn with patients. And today we're the largest digital platform, both in the B2B and the B2C context. We also own the largest remote consultation platform in India that keeps the patient at the center and connects it to practitioners. And that has done a peak consultation of about 15,000 consultations a day. And we also own the largest EMR platform in India, which is a productivity tool which can be used by the doctors to digitize their entire practice. So from record keeping to history management to symptoms findings, treatment, prescription writing. And that is now used by 6,000 doctors across the country. So as you can imagine, there are actually 4 distinct digital platforms and what we like to call the 5P network, right? So keeping the patient at the center and connecting them to the pharmacy, the pharma company, the practitioner, and the prescription, right? So these are the digital platforms that we're trying to create. And the idea is that we believe that the future of healthcare in India has to become digital, right? We are firm believers and proponents of a digitally connected healthcare ecosystem. And we believe that this digital ecosystem has in fact turned out in an extremely good stead in these times, right? Where in times of lockdown, in times where safety is a premium and people are expected to remain at home, I believe that platforms like ours have been of immense use, right? So there has in fact been to understand the criticality of what we're trying to do, right? And I do believe the fact that the Indian government has been encouraging digital platforms like ours, right? I think there was a conversation in Lighthearted in one of our societies that if I don't have rice, I can ask my neighbor for wheat. But if I don't have my medicines for antihypertensives, I can't have the anti-diabetic medicines that my neighbor uses, right? So having digital systems that provide these healthcare services on tap and on demand is something that's become very, very pivotal. So without going into how our business has benefited the society as a whole, I actually want to give an example of a case study that we've done with the Municipal Corporation of Greater Mumbai. What we did is very early on, the authorities brought us in as part of the war room constituted under the Epidemic Diseases Act to deploy our digital system. So one of the first things that we did is we actually deployed our digital EMR systems at Kasturba Hospital. Now, Kasturba Hospital is the premier infectious diseases control center for the state of Maharashtra, located in Mumbai. And right from the 20th of March, in fact, our systems have been used to digitize the entire patient interactions and patient records and adherence management. So imagine the plight when the entire physical paperwork has become digital, which has allowed doctors to periodically monitor patients who've undertaken any consultation, whether or not they have been positive or not, but to capture that entire time series of data and manage patients' health, right? And I think doing that digitally has been of great use. The second thing that we've been able to do is deploy our telemedicine architecture for the city of Mumbai. So again, from the 20th of March, we actually created a helpline number that was then integrated with the 1916 disaster management cell, where doctors of the BMC could actually attend to distress calls of the patient using that helpline number. And Mumbai was the first city to do that, right? So across the country, you had helpline numbers where counselors would help you on COVID. But we actually enabled teleconsultation on COVID, and the doctors could use our bot to classify patients, whether they were at high risk, whether they needed quarantine, whether they needed testing, or whether they just needed to be at home and take care of their health. And doctors could do this from any part of the city, right? So they could remotely log in onto our secure servers, remotely connect and manage this entire ecosystem digitally. And the third thing that we enabled is we enabled through our B2B marketplace, the health authorities to connect three ends, right? The demand at one end, the supply at the other end, and the donors at the third end, right? And what I want to actually bring out is that this opportunity is actually not, this tragedy, I'll put it the other way, right? This tragedy is actually an opportunity for us to overhaul our entire systems, right? And make them future-proof, if I were to call them. And I think it not just makes sense from the perspective of giving and from the perspective of being there and being the right social citizen for your city or for your country. But I also believe that this ensures that the kind of interaction and adoption that you see is a net positive for the business, right? So it's a win-win for you, it's a win-win for the city, and it's a win-win for the ecosystem. The kind of flip that we've seen towards the adoption of these digital services, right? And it has to start somewhere, right? People at large, authorities at large were always skeptical. The regulators always remain skeptical. Will digital services work? What about patient confidentiality? What about access? But I think when today you see that these patients are able to remotely connect with hospitals, and hospitals are able to remotely manage their patient records, I think the confidence in a digital ecosystem is right up there, right? Today, patients don't need to necessarily take a file which has hundreds of records. And even if you enable video consultation over a Zoom or even WhatsApp video call, the patient cannot show their records like this, and the doctors cannot keep flipping the pages. You need to have a digital ecosystem. On top of that, you need to have a digital ecosystem that will take these prescriptions and ensure that these medicines reach the patients at their doorstep, and that they don't need to go out and stand in long queues in order to get these things happen, right? And again, with all due respect, it's not like selling an FMCG product or selling groceries, right? Medicines are controlled substances. You need to verify authenticity of the prescription and have a controlled supply chain. But I think in times like these, when you open up and you give what you have for the larger good, I think it's actually coming back to us in a much more magnified manner, right? And I think that there is no better time for those who believe that they can contribute to the society to go out there without any expectation of it coming back. But I can tell you that when we went in with an idea of help and service. But I can tell you that once these digital systems get within the mindset of the people at large and the regulators at large and the administrators at large, the benefit is only manifold, right? For everybody, for the patients especially, right? And I think that this is one of the messages which I think I'm very proud of that we've not just given the system, but we've actually been a net positive to the healthcare ecosystem in India.
Yeah. That's fantastic, Siddharth. I'm sure both Dilip and Krishna, through their work as well, would have comments for us about the telemedicine aspects as well. So perhaps, Dilip, can we invite you to come in and tell us, and then after that, Krishna can take over as well?
Sure. Thank you, Manoj. As one would expect, as a hospital services company, a healthcare delivery company, our work has been at the front end of fighting COVID and actually taking care of the COVID infected patients. The easier part of it, Manoj, is that to allocate infrastructure to the hardware part of it. We have 16 hospitals across the country. And one of the first things that we did was in an underserved area, which, where one of our hospitals serves a region, to dedicate one entire facility to handle COVID patients from that region. That is one of the easier thing to do. And all our hospitals, we had the fever clinics and triaging centers and isolation areas and all that. And all our units actually saw COVID patients and were able to treat. But what I meant was this is the easier part to do, to allocate infrastructure or allocate hardware. What we felt glad about was the opportunity to build capacities. For instance, in one of the rare examples of a private sector hospital group working with the government sector is when the government of Karnataka invited us to help them manage the critically ill patients in the northern Karnataka districts. The early part of COVID infection in Karnataka in particular, a lot of it happened in Gulbarga, in Belgaum, and those areas. And the people were admitted there. While hospitals were there, they just did not have the critical care, talent that one needed to manage. So the government invited us to help them. And our doctors actually conducted e-rounds mornings and evenings for all these patients, managed parallel medical records with us, and was available on call for any consults during the day. So this is something which actually made a difference. The feedback is that we were able to help far more patients than otherwise would have been possible with the infrastructure and skills available in that part of the state. So that is one learning that we had. The second one was in actually training. That there were a lot of smaller hospitals or nursing homes which were worried about how to handle a likely suspect. For example, worried about aerosol. Even during the COVID time, if you need to do an emergency surgery, how do you protect your staff and your surgeons? And we were able to actually conduct programs for them, webinars for them, demonstration for them to see that they are safe, their staff is safe. So that's the second element on the training and consultation that we could do. The third one was, like Siddharth mentioned a few minutes ago, that rolling out, accelerating the video consulting options to ensure that continuity of care is available for patients. The chronically ill patients, the cancer patients who were worried to travel out or not able to travel out because of restrictions in movement, we could connect with them. And even when others, in public platforms were wanting to roll out on electronic consult kind of options, we could help them with guidelines and protocols. So while it is easier to give the infrastructure, like I said upfront, that it's the easiest thing that a hospital company could do, what gave us more satisfaction was the ability to maybe influence capacity building and also influence some of the government thinking. The final point I want to make is we are present in 7 states in the country, and we found that each of the state governments or the local administration handled the situation slightly differently. People had different approaches for the same situation. And we were able to maybe at times bring in learning from another state, try and influence the local policy, which would have helped the patients in that region. So apart from infrastructure, our happiness in the whole thing was the ability to maybe build capacity and influence policy.
Fabulous. Thank you so much, Dilip. And for the readers for our listeners who might have missed this detail, because I overlooked mentioning this as well, is Dilip is also the CEO of Manipal Hospitals, and they are present in all the states as he mentioned. And we'll come back to you to learn a little more about your experience and what we can take away from there. So, Dr. Krishna Reddy, please tell us about the work you're doing.
Yeah, Manoj, Access Health as a health systems area focus. We have been providing a comparative analysis to the government when it is asked for across the systems, across the countries, and also within the states, and try to extract what type of policy decisions have been impactful in different systems. So that is, I think, one of the activities that have been going on, both at some of the state government levels as well as at the central government level. But we are also studying the overall health system response to the COVID in India. So when I look at the health system response, be it the policy making, or be it the payer system, or be it the provider system, while everybody is aware of what has been the public health response, if I have to actually assess what is the response and compare with other systems, for the same starting point when the WHO gave the shot of health emergency, and if you look at the hard outcomes, what are the measures that have been taken by the different systems? The death rate, as far as India is concerned, in terms of the population density, is 2 per million. So that means, at least from a apples to apple comparison of different systems, which started at the same level, and the death rate of 2 per million compares far better than most advanced and most reputed health systems with very robust public health systems. So there is, I think, the great learning that whatever the policy decisions, whatever the interventions that happen in the public health system, going down to the ASHA workers, is yielding results in terms of the public health outcomes of the epidemic. Now, as we start adjusting ourselves to living with COVID, the new normal, so when we look at the role of the private healthcare delivery system, the private health insurance payer systems, I have a concern, great concern, that because we are a mixed healthcare system, and because 2/3 of the healthcare is provided by the private healthcare system, we are not really prepared. I mean, that is what worries, that the private healthcare system as a system, because it caters to such a large population, their health needs, both COVID-related health needs as well as non-COVID-related health needs. In terms of the preparedness, I mean, Dilip has mentioned about how the Manipal is getting prepared and how it is responding to the COVID. But in the absence of a steering mechanism, in the absence of a governance mechanism for the entire private, because it's a fragmented system, everybody is individual. Unlike the governance system, where despite its fallacies and the limitations, there is a coordinated, concerted response going down to the ASHA worker level across the country, across the states. So I think there is a need for this type of leadership, or the steering or the stewardship to the private healthcare response, because the big hospital chains, which may be responding appropriately, cater to only 4% of the health needs of the population. The 96% is provided by the general practitioners, the clinics, the Ayush workers, the nursing homes, and the small hospitals. If you ask them what is the preparedness of these hospitals in terms of triaging the patients, protecting their staff, protecting the patients, protecting the families, notifying the appropriate authorities so that they don't spread in the communities, I think there is, we need to reflect on this aspect in terms of the preparedness, protecting the people, and more importantly, the partnership that is required. I'm not aware of any effort to pool up the resources. I mean, to at least know how many ventilators there in a particular city or a particular state among the private healthcare providers. So this is, I think, one aspect that we are trying to address and maybe articulate with the concerned associations and the representative bodies, whether they can give that leadership position as a concerted, unified response of the entire private healthcare system. Similarly, we don't see a similar response from the payer system, because people don't announce what are the benefit packages they're going to cover. in some of the advanced systems, and the private health insurance or the public health insurance are offering advance payment to the empaneled hospitals so that they don't get stuck in their response because of the cash flow problems. So yeah, these are some of the areas in terms of how the system is responding. Mind you, I mean, we are a mixed healthcare system, and the whole body of private healthcare system is rudderless. At an individual facility level, at an individual institution level, each one will respond according to their means, but there is no concerted, coordinated, collaborative effort across the private healthcare system. I think these are some of the things that we are studying. Maybe we may have to reach out to some of the representative professional bodies or industry bodies, whether they can rise to the occasion and provide this leadership. The huge gap is there.
Thank you, Dr. Reddy. Actually, this is a really good sort of point where I think we can call on Nachiket, and your point about the need for coordination also highlights something that Nachiket had been mentioning on previous conversations. That so Nachiket, when you come in, if I can ask you to, of course, tell us about what you're working on right now, but also use this as a starting point to help us think about sort of the public goods nature of some of these investments versus the sort of focus on public systems responding to the COVID crisis. And and then maybe after that, maybe we'll start with you helping us think about how different industry players can contribute to the process. But perhaps we'll start with the first part of you telling us what to do, and then help tie it to your point about the public goods versus public resources and public systems. Please, Nachiket, over to you.
So thank you to Samhita and IDFC Institute for inviting me to participate in this conversation. It is an important conversation, and I'm glad that I have an opportunity to listen to all of the experts that have been assembled here. I am an independent researcher, not at all with the kind of expertise and background that the previous speakers have. And most of my role has been to try and assist other efforts that are ongoing to try and see how they can, be more impactful, be more sharp in terms of what they're doing. So there are three broad areas in which a lot of my work is. One is what I would say collaborative work with the government. I'm associated with a few efforts that are working at a number of central and state government levels, helping to build an interactive voice response system in Karnataka, helping to power the war room, as it's called in Kerala, helping to jumpstart the supply of protective equipment for providers across the system. So these are kind of efforts in which there is a strategy already laid out by the government, which is hospital ventilator centric. And how is it possible for private resources, private players to see how they can contribute, in part with money, but money, frankly, the needs are so high that one would have to turn to government resources to address the pure financial challenge. But more supply chains, getting things jump-started, getting manufacturing going where perhaps it may be harder for a government system to step in and fix a particular problem. So that's kind of been one area. The other area of work, from what I understand now, I heard many people talk about, how well India is doing, and I'm certainly hoping that that is indeed the case, and I'd be delighted if we ended the year or 2 years with the same conclusion. But I do worry that there's nothing we know about the virus that tells us that India will be different or unique in any way. From what I hear from virologists, from what I hear from the scientists, is that, we are seeing only a part of the elephant. We are not really seeing the overall picture. So I am certainly concerned that perhaps our response so far, which is quite effective, has a little bit of a character of European approaches transplanted here. Where the focus on hospitals, ventilators, isolation wards, large lockdowns, are very much character of what you see going on in more advanced countries. Now, if the infection rates remain roughly where they are, which in Bombay, they have gone beyond that number. But we might find that actually these systems that we have built are very quickly overwhelmed. And we will need complementary capability to be established. And some of the conversations I've been having with, including people on this talk, have been to see how can we build better preparation for a set of numbers that might be larger than we imagine. I personally feel that working more closely with civil society that is working deeper in the community, trying to understand what specifically can be done with 60 plus individuals, working with the very large primary care provider network that, for example, Pharmacy has, others have, and seeing how they can build better capability, not just to identify and to contact trace, which is perhaps still important, but much more to see if we can build oxygen capability at that level. So that, because the evidence so far seems to be that people who go on the ventilator, their mortality is actually quite high. But if we can give them relatively straightforward oxygen treatment, we can actually do a lot more. And nothing that I've seen so far suggests that that needs transportation to an intensive care unit. There is a risk of rapid decompensation, so you have to be careful with your protocols. But given the size and breadth of our country, given the shortages that we have, I think a complementary approach is certainly quite important. The third area of work, I'll just briefly mention that it's kind of similar to the point that was made by Farnese, is that is there an opportunity that this crisis presents itself to maybe even do something transformational in India? Because we also have to remember that there is a lot of ongoing non-COVID disease burden in the system that needs to be addressed, was already pending to be addressed, even in a highly advanced state like Kerala. But now with this new COVID focus, that burden seems to be growing. I understand that some of our vaccination schedules have gone, haywire, and now we're going to have a situation in which a fairly large population of children may not actually get vaccinated on time. So is there an opportunity for us to, while continuing to serve, collaborate, complement, to also transform? There are some steps that are being explored, some coalitions that are coming together to try and do that work. Again, there's an opportunity there. I feel that needs to be explored, both to address today's needs, but also to prepare our systems for the future. So I'll stop here, but that's kind of what the work I'm doing.
So Nachiket, while you still have this, maybe I can just turn around the order and start with asking you this question. Since you mentioned some areas which you think which would be ripe for future investments, whether it's around preparing the system better or investing in home-based approaches to try and provide high-flow oxygen and home and community-based management or transformation of the system, how can we think, what kind of advice would you and all of the panel members as well, we'll ask the similar questions, sort of recommend to three types of actors in the system: actors who are already involved in the business of healthcare, private sector players, how can they contribute better? And also other actors, this is the second type of actors who are not directly involved in the business of health or healthcare, but have traditionally supported this work. What alternate areas can they branch out into? And I think the third one, which probably might be the biggest group, which are large private sector players, but are not working currently or thinking about health, but recognize now that health is really important with the kinds of challenges that all of you have mentioned. How can they bring their resources to bear to help us out on this journey? And if you can also, in this time, think about, I want to be careful that we have only about 20 minutes before we bring in audience questions, but also think about how, what kinds of challenges we can surmount with these additional support from the private sector players. So yeah, perhaps you can start off.
Yeah, I'll just make quick comments. I'm actually eager to hear what some of our more expert panelists have to say. Yes. But I would say that, the approach that I have certainly found interesting is one in which each organization identifies a community that they care about, that they are engaged with, that they are embedded in. Is it, communities around your factory? Is it your employees and their families? If you're a large company, you have a very large community of people that you work with. At a panel discussion we had, the Hindustan Unilever CEO. Now, I didn't know the number of the scale. 95% of Indian households come contact with Hindustan Unilever. Now, that's an amazing community of people that one engages with. But what can one do to safeguard this community? Can one identify the unique thing about this disease? I happen to believe, I don't have the expertise that many of the people here have. I happen to believe that there is no reason why this will not spread to 60, 70% of the population. I do not think those numbers are overestimates. But it has a unique mortality profile. It is impacting a certain age group far more than any other age group. Now, of course, in India, things could be different given our malnutrition, etc. Now, is that something that tells us that if I'm thinking about a community, can I really segment some of these people based on the evidence I have today to do some work? And I have been working with some groups to do exactly that, to see if those communities can be managed well. Second group, organizations like PharmEasy and others who are not directly healthcare providers, but are deeply engaged in the ecosystem. What can they do to enable their ecosystem to do more? Can the pharmacist, for example, given the new telemedicine guideline, worldwide, India is one of the exceptions. The pharmacist is a key partner in non-communicable disease management. We treat the pharmacist as merely a dispenser of medicine. Is there something that can be done to enhance what this person does, which we may not have done earlier, but given the reality of today, is that a possibility? And of course, those that are directly involved, they are already doing a lot. I wouldn't say that, but there is some concern that a lot of providers, particularly the individual providers, the primary care providers, have withdrawn from active engagement with the public because they're concerned about their own health and well-being. I would say there's an opportunity to re-examine that stand and see if there is something that they can do to step out and actually do more than what they might have done in their usual practice. I spoke about the oxygen. In my mind, the oxygen issue is not a home issue, but very much something in a small clinic. And there are already players that are doing this, that are able to put an HFNC integrated with a helmet or a simple oxygen cylinder if they don't have any other capabilities, so that they can start to give 5 to 6 liters of oxygen to somebody that experiences hypoxia. So I think these would be the areas that at least I would think about, taking some action. But as I said, I don't really have that kind of expertise. I'd love to hear from the other panelists what they think.
Fabulous, thank you. Dr. Krishna and Dilip, maybe you can tell us from the hospital system's perspective as you're thinking about it, what would you recommend to players who would like to jump in and help?
Yeah, see, I think all of us should realize that the healthcare provider facilities have the greatest risk and potential to transmit the disease to uninfected people. That realization, whether it is a pharmacy I see while traveling on the road, just people crowding at the pharmacy, and the pharmacist not wearing even a mask. Similarly, when we go to the hospitals, there is no triaging at the entrance of the hospital so that other people are not exposed to the risk. I mean, just like the work from home has become the new norm in the next 2 years of social distancing, we may have to start thinking of the direct-to-home service delivery. I mean, I think every goods delivery and service delivery has extended to non-health sectors already, even the pre-COVID times. But what COVID has done is that there is a need, actually, it is not a choice or an innovation, but there is a need of delivering healthcare direct to the home, which is the most, I think, safest and effective method, so that the people, especially the vulnerable elderly people with comorbidities, they don't have to come out of the homes. In fact, getting exposed to the risk of contacting the infection in the process of just getting their health needs met. It is easily doable. I think it covers across the sectors, non-health sectors and the health sectors. You can deliver care at home through the virtual services. You can have home care delivery systems which are already operating. We have home care diagnostics which are already operating, and the pharmacy, the drug delivery system, even using the drones to deliver the drugs, it's happening. We see a very effective method of vegetable vendors coming into the communities. See, we have seen when the people go to the mandis and vegetable markets, how it became the super spreaders for the infection. But if somebody brings vegetables in a cart to the houses, that is much more safer. In the same way, why not mobile clinics be there, so that the people who are well trained, well protected with all the PPEs, take the mobile vans to each community so that the healthcare needs of these people can be met. The entire public transport network, be it metro coaches or the public buses, they can be converted into the mobile clinics. People don't have to come out of their houses, especially the elderly, vulnerable people. I think this is one area I would suggest. I think it can be taken up by multiple sectors to make it as a future normal, actually, not new normal, but the future normal. Which is most convenient and effective, and it reduces the pollution. So many beneficial effects are there. So this is my, I think, a recommendation I can think out of the box as to what a healthcare delivery system can do. Instead of expecting people to come to their hospitals, why not the hospitals move to the homes?
Thank you very much. Dilip, I'm curious to hear what you would say about that.
Yeah, Manoj, let me bring a slightly different angle to this, a dilemma that private healthcare providers find themselves in. Perhaps a little sensitive subject, but let me put it out there. Like Dr. Reddy mentioned earlier and some other panelists mentioned earlier, a large segment of the capacity in India is in the private sector. Over 60% of the beds and maybe about 80% of the critical care beds are in the private sector. And apart from a handful of charitable institutions, the rest are, for-profit or commercial enterprises or livelihood enterprises. Many of the large networks are listed companies. Many of the other, even unlisted large networks have private equity investors and other stakeholders, who also have an economic return expectation, from their investments. And if you look at the smaller nursing homes, even the very small hospitals, they are all livelihoods for a group of doctors or a family. So what has happened in the last month is that many of these smaller enterprises are facing significant cash crunch. It is not unexpected because given the mobility crisis, and also that many of the hospitals have stopped taking patients other than urgent work or COVID patients. Many hospitals are finding it difficult to sustain a month like April for many other months to come through. If you look at the tier 2, tier 3 kind of towns, smaller hospitals are beginning to shut down. And, they're saying we will reopen. They're telling the staff, we'll reopen maybe 2 or 3 months later, we'll be in touch. So at a time when India requires all the beds at disposal, we are beginning to lose capacity, from the system. And what we also should understand is during COVID time, there's also a large set of non-COVID patients to be taken care of, who've got chronic diseases. One quick statistic I want to quote is that India does about 650 to 700 renal transplants a month across the country, across all kinds of facilities. In April, there were 20 transplants. So what it means is there were many lives which are already maybe lost for non-COVID kind of reasons. And if the private sector is finding it difficult to sustain for whatever reason, economic reasons, then we are beginning to lose capacity. And that is something we would need to keep in mind. So when the government looks at the private sector at the moment, there is a mindset issue, maybe built over the last decade, last maybe 5 years in particular. While everybody is willing to help, willing to get into the fight with COVID, I think the ability for the smaller private players, at least the first level of defense that we have at the primary level, secondary level, is ebbing away, something we would need to keep in mind. That is something I just wanted to put it out there. With all the good intentions, I think we may be losing capacity at the field level soon.
Dilip, can I also ask you to just one more quick comment on, is that an area that other private players can support in this case, or is it really a matter of firms such as yourself investing in yourselves?
Perhaps there is an opportunity if, for example, if CSR funding could support nurses or technicians being paid at a small community nursing home somewhere, that may help it run for a few more weeks or a few more months. What I've seen in the last month is that a lot of our corporate fellow citizens are willing to help. They are willing to contribute funds. But there is also, as Dr. Reddy mentioned earlier, there's no concerted effort. The early April saw a lot of talks about the need for field hospitals, and a lot of people who are experimenting with that. Attentions were were maybe spent on a few other areas which were not an immediate priority. If you ask me as a provider, in the month of April, the most difficult issues that we faced were the lack of PPEs, the lack of integrity of supply chain, lack of training at field levels, which was to keep the smaller nursing homes and hospitals up and running. Whereas a lot of effort that time for maybe looking at what happened in other parts of the world, maybe what happened in Italy or Spain, a lot of efforts were diverted to looking at the feasibility of field hospitals, converting railway compartments into hospitals, and so on and so forth. I think the ability to channelize the resources into priority areas is what is missing. There is money available, there is willingness, but I think pulling it together and deploying it for a purpose which is relevant at that point of time, I think that is missing a bit much.
Thank you very much. So let's turn to Siddharth and then to Shamika to hear their views on what these private partners, potential partners, could help us with. Siddharth, please jump in.
Sure. So I think one large area of interest is the ability to, and I would take the point put together by Dr. Moore earlier, right? For people to identify areas of their own expertise, right? So what he calls as communities, I would call them as areas of expertise for a given company, right? And see what can be done. And I would encourage people to look at creating radical models, if you can call that, right? Or creating models that are so-called future-proof, right? Just like the way we are talking of social distancing or work from home as a reality. I think that there is an immense amount of opportunity that exists in each of the areas, right? I think one of the panelists earlier was speaking about aerosols. Now, a couple of days ago, we came across this, that there is a certain company that is able to replace dental procedures which necessarily involve aerosol, right? And replace them using technology for 3D scanning and 3D printing of your dental crowns or your aligners, which you need for aligning your teeth, or even for implants, right? Now, what you're doing is you're taking an industry that has not necessarily changed for 100 years, right? That typically involves using a burr and a rotor in order to take care of your dental problems, which will necessarily lead to creation of aerosols. And these aerosols will affect, if the doctor is protected, it will affect the next patient who opens their mouth. But can you create non-touch, non-contact procedures, right? Now, the moment you try and do this, as a community of dentists, the first pushback you're going to get is the fact that, hey, am I letting the premium of my skill go away, right? A dentist or an orthodontist is known for the skill with which they can perhaps put your braces and tighten them and apply all their years of expertise. But now you're saying that I'm going to replace that with 3D scanning, with 3D engineering, with 3D printing. Now, can you marry technology along with your understanding of that domain to completely re-engineer the process grounds up, right? I think this process is going to be painful, right? But this is just an example of something which is outside my domain that I came across, where I think that you will see an unbelievable level of digital transformation, and you will see an unbelievable level of consumer flight towards safety, right? And I think we will have to re-engineer ourselves as flight towards safety, because I don't think that we're only going to look at lockdown. There is going to be life after lockdown till you get a vaccine. And the re-engineering in that process is going to be very, very critical. And I think even if companies don't want to think as providers or giving CSR or giving money away to somebody, I think investing in something like this is also a great service to society. Because it's not that people will not need orthodontic treatment, because kids, if they pass a certain age, it's going to be difficult. But re-engineering yourself for that, in my opinion, is also giving back to the society in some way, form or other, right? Similar examples that we are hearing, especially closer home in our pharma industry, our digital EMR platform saw about 40,000 patient records being created on a daily basis in the month of February. This number dropped down to an average of 6,000 in the month of April. This means that more than 80% of patient-doctor interactions have gone down. That number has come back from 5 to 6,000 to about 12,000 a day. But the balance 6,000 are still remote consultations, which are being done. It's still much lower than the 40,000 that we saw. But is there a way to create a virtualization for these doctors? And one of the messages that, again, we've seen is that pharma companies are going to face issues, right? Because how are they now going to get sales reps to go and talk to doctors, right? If doctors are unwilling to see patients and patients are unwilling to see doctors, I dare not say that doctors will be absolutely unwilling to meet pharma reps, right? But how do you engage this huge community of pharma reps to create an ecosystem which is, again, 2 steps ahead, right? For the companies, for the doctors, help them in a digital transformation, right? So maybe it may seem like I'm playing the same record over and over again, but at least coming from the perspective of a company that is working at the forefront of recreating systems in a digital first manner, I do believe that investment in your own company in a digital first manner is also a great way of giving back to the society, right? And this is the time for you to reappend, rethink, start with a zero base, right? And I think this is the best opportunity for us to do that, right? It also gives you time to focus on the long run versus the here and now. I understand that a lot of people, companies, operations are not working, but this is the time to consolidate and reimagine from grounds up. And I think there is a huge opportunity to do that today.
Thank you, Siddharth. I never like going to the dentist, but now I definitely will wait to see whether 3D printing comes in before I go back there. Shamika, over to you. If you can help us think about, what kinds of investments could be really strategic and helpful at this point, that would be great. And then we have some questions for you as well, Shamika.
Yeah. So, well, first of all, let's go back to the way the private sector is it's a major player in India's healthcare sector. It's important to reiterate that point, even in the middle of a public health crisis that we are, because obviously there is overwhelming focus on the public health aspect of this, but 75% of OPD, the last I checked, was in the private sector. 55% of IPD is exclusively private sector, which seems to suggest that the sector obviously is a very major player and will continue to remain one. Now, I'm giving you national level statistics. You can imagine that if you break it up at state level, you will have states where this number goes up to 90%. All right. So there are many states which are overwhelmingly, and UP, Bihar, MP, Jharkhand, there are several states that are overwhelmingly reliant on private healthcare service for most of their needs. So I think it's important to reiterate that point, because people, and particularly in the policymaking arena, tend to forget. And I think sometimes also the industry forgets to reiterate that point, why they are major players, because in the current setup, see, the lockdown is having a major impact on every aspect of the economy, right? You are seeing falling revenue. Firms are trying to readjust their capacity, trying to, come up with some sense of what will be the capacity utilization. once the lockdown begins to get lifted in whatever calibrated way that it will. But the healthcare sector cannot be just another part of the economy suffering currently because of the lockdowns that we have, simply because they are again at the center of the care, they are sort of partners in dealing with this current public health crisis. So I think it's important, first of all, for the healthcare sector to also have a better representation. In the absence of the sensitivity from the state itself, I would like to say that, the representation of private healthcare cannot be just another sector out of a CII or a FICCI or an ASSOCHAM. I'm sorry. I think it needs to be far more concerted, concentrated, and forceful, because it is strategic in nature. That is number one. Number two, frankly, this is something many of us have been writing now for many years, but I cannot imagine a better opportunity. India has to look at a future growth engine and an investment strategy which is centered around healthcare. It's not just because of the domestic demand, which is only going to grow, because that is the nature of, demand for healthcare everywhere, but also because we have very large gaps in our health, needs right now. Given the demand and the kind of infrastructure and services that are available, there is a very big gap. So one growth potential is just that. But strategically, I think also looking externally, the global market, OECD countries are aging. They're all faced with escalating health costs. They're all looking for opportunities to reduce costs. So I think India has a very important role to play in terms of thinking strategically from the perspective of healthcare, becoming its future engine of growth, or let's say the IT sector equivalent for the next 50 years. So I think that strategy is very important for us, many of us, to continue reiterating. And I'm hoping that as the economic package unfolds, we've heard, the first, other than the humanitarian sort of package announced earlier, the economic package that the finance minister rolled out is mostly MSMEs, etc. But I'm hoping the next set of announcements will be centered around health, because I do believe it's of great strategic interest. But, this will involve expanding the telemedicine space. One of the reasons why we are frankly trying to do a lot of policy making in the absence of data, in the absence of real evidence and localized evidence. In fact, many of the research references that earlier Nachiket also made, ventilator versus oxygen, elderly, whatever we know, there's 80, 15, 5%, not asymptomatic, not needing care, hospitalization, ICU, ventilator, etc. Very few, almost none of them are born out of Indian data. We are really borrowing knowledge from the existing, crisis in the other countries. And one of the reasons that we are still looking at national level and state and at max for some cities, and not patient level data, is because we don't have an electronic health record by virtue of which we can actually begin to analyze some of those very important aspects of this outbreak, which can help us manage it. So I think the electronic health record, enormous, growth potential, and frankly, a requirement as far as it should be an extension of the giant trinity that the Prime Minister keeps talking about. So, having health records and portability, etc., is part of it. Pharmaceutical industry. We call ourselves the pharmacy of the world for good reasons, because 20% of generic drugs, is supplied globally from India. But clearly, with the kind of self-sufficiency and self-reliance call that we are seeing, the reliance on China for a lot of the inputs are only going to get more costly, right? And costs of all different kinds, which means the pharmaceutical industry will also have to have a growth vision. We are again now thinking strategically. Health IT. Many international, care providers are looking to send, just like the mainstream IT sector did in the early 2000s. Health IT is a very, it's a very specific type of IC, where you don't have nurses and doctors wasting time feeding ICD codes and learning how to enter health data. We need an entire cadre of people really trained in exactly that, because that is how you manage the future of a modern sector such as this. So there are very many aspects of the health sector, Manoj, which I think we have to look at it strategically as an opportunity. Despite the crisis we are in, I do think a crisis would be, it's an opportunity and too good to be missed right now. So I do think that the industry has to make a much better representation of why it's an important partner and moving ahead, why that growth engine can very much stem out of this particular sector. Thank you.
Thank you so much, Shamika. So we'll now move